Good evening, ladies and gentlemen. Welcome to Mr. Coco's Nesses class. So this time would like to look at respiratory distress syndrome. So this topic is very important because it's examinable in your NMCZ exams. So it's better you get to learn about it. Then if you look at respiratory distress syndrome, meaning that we're looking at a condition that is coming from the respiratory system. So in this case, you have to know how to draw the respiratory tree because sometimes that diagram comes and it's about 15 marks. Okay, so that's how it is. Then how is it abbreviated? We abbreviate it as RDS. So if you look at there, we've said RDS, that's what we do. So this is RDS, so that's the abbreviation. Whenever you hear RDS, it's respiratory distress syndrome. Then why have I put this here? Hyaline membrane disease. Okay, so you find that sometimes NMCZ will ask you the other name for RDS. What's the other name? So the other name is hyaline membrane disease because we know that the hyaline membrane is found in the alveoli, and that's where the gaseous exchange will take place. So, and that's where the disease, hits. So, let's see now what goes on. So, if you look at this diagram here, it's just anatomical structure trying to show the respiratory tree. So, this is an example of what you can draw, but you can find even other diagrams on internet, or you can check your literature. So this diagram here, when you draw this diagram, ensure that you include the title. If they've said anatomy of the respiratory tract or just the respiratory tract, you just do there and draw. So put the title, then draw the diagram below. That's what happens. So most it carries 15 marks. Okay. Then let's look at now the introduction. We'll look at the introduction. So we're saying RDS, the previous name was hyaline membrane disease, so they'll ask you about this, like I said. And where does this condition occur? Mostly it occurs in premature infants. Okay, so mostly this condition affects premature infants. And then how does it develop? This is because of what we call surfactant. So there's a chemical which is produced in the lungs we call surfactant. So what happens with it is that when it's insufficient or reduced in the lungs, that's when an infant will develop this condition RDS. So mostly when you're dealing with RDS, just remember surfactant, and that's what this is based on. Okay, then let's look at the definition. When we go to the definition, we're going to say that this condition, like I said, it affects infants, so it affects the newborn. Okay, so it affects the newborn, and then in which the lungs are imperfectly expanding. Okay, so meaning that the lungs are not expanding, correctly. So it's about lung expansion. So if they are not expanding correctly, or they're imperfectly expanding, then you know that this is RDS. But then what is the cause? The cause I've said is a reduction in surfactant, which is saying insufficient surfactant. So whenever you just see low surfactant, and then we say that newborn with low surfactant, then the lungs are not expanding perfectly, you get to know that this is RDS you're dealing with. Then the characteristics would be tachypnea and grunting. So in this condition, you expect grunting as the main thing which is there. So as you define RDS, remember to say it's a condition that affects newborn, then the lungs will not perfectly expand, or they will imperfectly expand, which is as a result of insufficient surfactant. Then it's characterized by, you can put tachypnea or expiratory or respiratory grunting. And that's what happens. So some people would be wondering what the word grunting is. So I've tried to put what grunting is there. So grunting, I've put it. So grunting, these are just sounds which are made when somebody tries to exhale, meaning that somebody is trying to expire that air from the lungs. So when air is coming out of the lungs that with that noise, we call it grunting. Okay, but it's not a stridor. Just remember there's a difference between a stridor and a grunting. So grunting is just noises that can be heard or sound. Then in your NMCZ questions, you discover that they'll ask you why grunting is important in RDS. Grunting is important in RDS. I've put this remark here. So grunting is important in RDS because this is the way the body will try to keep air. So I've put it here for you. The body will try to keep air, okay, inside the lungs. So the body will try to keep air inside the lungs so that at least there is a buildup of oxygen within the lungs. So it's trying to just improve the O2. Okay, that's why grunting is there. So grunting just helps the body to keep the amount of air in the lungs so that at least there's an increase in O2. Okay, that's what happens there. Then let's look at now the cause. So now we know the cause. The cause for RDS would say that there's only one cause, of which we know the cause. Now, the cause is just insufficient what? Surfactant. So it's just insufficient surfactant. In which lungs? Immature lungs most of the times, but there are other predisposing factors, but mostly it's just immature lungs that can be there. So the issue in RDS, the cause is just insufficient surfactant. Then just supporting sentences would say that when would you expect surfactant to be found in amniotic fluid? So we look at that, we expect it to appear in amniotic fluid around 28 weeks to 32 weeks. So this is when it's expected to be there. So even if somebody does what we call amniocentesis, this is the period when surfactant will be expected to be found in the amniotic fluid, just around that period. Okay, and that's when you can extract it. Okay, so now another question that you expect in NMCZ question about RDS, there is completion and MCQ, so it's this point which I added here. So how does surfactant work? Okay, so surfactant works by this point here, by reducing the surface tension. So remember, when you go into the questions, you discover that they'll ask you to say that they'll try to confuse you to say surfactant increases the surface area or the surface tension. But here we learn that surfactant reduces the surface tension. But there'll be options which say it increases surface tension, what, and all that. But for you, just know that surfactant reduces the surface tension, meaning that surfactant prevents the air spaces from completely collapsing. That's what it means. It will reduce the surface tension, thereby reducing atelectasis or collapsing of the airways. That's what happens. So this is the point. This is what you find again in MCQ. Okay, even that above there for amniotic fluid when it's found in when surfactant is found in amniotic fluid. And then let's move on now to the predisposing factors. Now we know the cause. The cause is insufficient surfactant. Some will say deficient surfactant or deficiency in surfactant, like here, okay, which leads to collapse in the lungs. So sometimes you find to say they'll ask you what do we call the collapse of the lungs, that you find it in completion. So that is atelectasis. So now the predisposing factors, meaning factors which will lead to maybe a reduction in surfactant production. Okay, apart from what we've discussed like prematurity or immature lungs. So these are here. So you discover that the cause which is established is deficient surfactant. Now, what are some of the things that will lead to that deficient surfactant? So number one will be prematurity. Okay, so all these are even below, just predisposed to that. So prematurity, meaning that the child will have immature lungs. Then perinatal asphyxia and hypoxia, meaning that this is dealing with the lungs, obviously with difficulties in breathing, so it affects surfactant production. Then hypothermia, stroke cold and stress suppresses the production of surfactant. So even just keeping the baby exposed to the cord, to have reduced surfactant production. So even hypoglycemia, when the child is hypoglycemic, you expect the child to have a reduction in surfactant production. When you go to this point here, which is hypovolemia, we expect the same. Hypovolemia, we're looking at a reduction in the fluids, okay, in the blood or in the blood vessels, a reduction in the blood volume. That's what you expect. So you expect also a reduction in surfactant. Then perinatal infection. We're looking at infection affecting these babies, okay? So if a child maybe is born or just in utero, it has an infection, it to have a reduction in surfactant production. Others will be like say multiple births, which is here. So like twins or triplets, they also expect them to have a reduction in surfactant. Then we can also have what we call diabetic mothers. Diabetic mothers, when they're pregnant, their infants tend to be so big. So, but then what happens there? They're big and they would look mature, but then the production of surfactant will be low. Okay, so what happens is that too much insulin in the baby's system due to maternal diabetes can delay surfactant production. The baby can look big, but it will have too much insulin, and then this will delay the production of surfactant. Then babies with patent ductus arteriosus, this is a heart condition, so they'll also have a delay in the production of surfactant, or they'll have insufficient surfactant. So all these factors, they have a reduction in surfactant production. So these are the factors that we have. Okay, then let's move on. We go to the pathophysiology. So this is one of the parts where students hurt. They don't like pathophysiology, but pathophysiology is good because it helps you understand the condition. So in this case, in RDS, which is respiratory distress syndrome, we're looking at the first thing that is affecting the baby is deficiency in pulmonary surfactant. That's the thing, that's the marker, this word deficiency or a reduction. So what is causing a reduction? Sometimes we've now looked at those predisposing factors, and one of them can be lung immaturity, say in premature babies. Okay, so that's what happens. So then if you look at that, then what would be the impact of having a reduction? Okay, so the issue is that what would be the impact of having a reduction in surfactant? That's what we want to establish. So let's look at this point here, where I was saying that the infant may breathe, okay, with minimal difficulties, which is here. They may breathe with minimal difficulties, but then that's in the initial stages when they are just affected. They'll just be breathing with just minimal difficulties. But what happens later on? Later on, as the condition progresses, surfactant will begin to reduce. So when surfactant reduces, therefore, it will cause what we call labored breathing or dyspnea. So it will begin causing labored breathing. That's what happens. And why is this happening? Why is the child having labored breathing? It's because the lungs are not expanding, or the alveoli are not expanding, meaning they're not allowing gaseous exchange. That's why this labored breathing is coming in, because of reduced surfactant. Okay, so as a result of this labored breathing, what will happen is that the infant will become fatigued, meaning that the infant will become very tired. Okay, and then more alveoli cannot open. That's what will happen. That's the thing which is here. More alveoli will not open or cannot be opened because there is no surfactant which helps the alveoli to open. So since the alveoli are not opening, the issue is that the child will go into, what we call atelectasis. So this is another point where I was saying that surfactant deficiency, will cause the lungs to collapse, which is here, or the airways to collapse, because what's happening here is that there is nothing to open the alveoli up. And what opens the alveoli up is surfactant. Now, surfactant is not present. That's why the lungs are collapsing. So what do you expect when the alveoli collapse? Okay, there is now what we call pulmonary vascular congestion, meaning that there are those blood vessels which are supposed to be helping in gaseous exchange. They also collapse. And then what will happen now to the blood which is supposed to be going to the lungs? There will be what we call hypoperfusion, meaning it will reduce. Even the blood flow to the lungs will reduce. So this is a major problem. Blood flow to the lungs is reduced. The lungs are not expanding because the alveoli have collapsed. So this is what we find in RDS. Okay. So then, if we look at this point, we are saying that the hairline membrane, and this is why we get the name hairline membrane disease. The hairline membrane lines the spaces, hence blocking gaseous exchange. So now, gaseous exchange will be blocked, and we know that what is involved in gaseous exchange is oxygen and carbon dioxide. So now what will happen is that oxygen will not be picked up to go into the body because the alveoli or the lungs are collapsed. Then carbon dioxide from the body will not be unloaded. That's what we're having a word unload here. It will not be unloaded or removed from the body because the lungs are collapsed. Then what will happen now is that blood oxygen levels will fall because there's no oxygen coming from outside the environment to go into the body. So if oxygen is not going to the body, then carbon dioxide will increase. That's why we're having a rise in carbon dioxide. So oxygen falls, carbon dioxide rises. Then what do you expect when carbon dioxide rises? It will cause what we call acidosis. So that's why we have the acid levels here rising and hypoxia. So we have a reduction in oxygen in the tissues. And we have an increase in the acid levels in the body. So if we have all this, what will happen is that the child will become just hypoxic, or it won't have oxygen in the tissues. Then what will happen now is that the child will have atelectasis. Atelectasis, like earlier on said, this is lung collapse. So if a child has lung collapse, what will be happening is that the child will continue having hypoxia, hypercapnia, meaning that it will be breathing extensively, then carbon dioxide to still rise in the body and all that stuff. Okay, then hypoxia, consequently, what will it cause? It will cause an individual to break down the glucose without oxygen, and this we have said that it causes acid levels because carbon dioxide has increased. So the acid levels, we are saying lactic acidosis. Okay, so this is all about the acid. Even metabolic acidosis, we are talking about the acids because of carbon dioxide which has increased. So an increase in acidosis. Acidosis is all about carbon dioxide which has increased in the body because oxygen is not going in. So acidosis, as it increases, it will cause what we call capillary damage and necrosis. Then necrosis in the alveoli, again, you know what will happen is that the production of surfactant will not be there. Okay, so that's why the last point says here that which again suppresses the production of surfactant, meaning that if there is just acidosis itself, surfactant here will not be produced. Even just the body trying to attempt to produce surfactant, still it will fail because the CO2 in the body has risen. That's what happens. So this is the pathophysiology. This is the damage which is caused. As you can see, it's all about oxygen, which has reduced, carbon dioxide has increased in the body, causing acidosis. Okay, so let's move on to the clinical manifestations, or just the signs, or clinical signs and symptoms, you'd call them. Okay, so looking at the issue here, the issue is carbon dioxide increasing, then oxygen reducing in the body, then also lung collapse, which we're calling atelectasis. So what will be the issues that the baby will present with? So the baby will present with one, what we call tachypnea. So those who are dealing with fundamentals, tachy means this tachy here, it means fast. Then pnea means breathing. So it's a fast breathing. So tachypnea is fast breathing due to respiratory acidosis. We have established already to say that there is a lot of carbon dioxide leading to lactic acidosis, or we're saying respiratory acidosis. This is all about carbon dioxide. So carbon dioxide is too much, that's why the child is having tachypnea or fast breathing. Then there's also what we call cyanosis. When we look at cyanosis, we're looking at the bluish discoloration of the skin. So the child will become blue because of an increase in hypoxia, meaning that the tissues are not receiving enough oxygen as a result of lung collapse. Then the child also have flaring of the nose. Flaring of the nose is more like the nostrils are opening and closing, like they're just flapping. So that's flaring of the nose. Why would the nostrils flare? It's because of labored breathing. We know that labored breathing is as a result of reduced, say there's a reduction in oxygen, there's an increase in carbon dioxide, then there's atelectasis. So labored breathing will come in. Then an infant will be lethargic. Then another question that they ask you will say, in which condition do you expect a child to assume a froggy position? So this is RDS. In RDS, a child will assume a froggy position because of generalized reduction in muscle tone. That's why the child will have or assume froggy position or a frog position. Okay, and it will become lethargic. Then the child also have grunting sounds. Why would the child have grunting sounds? This is because during expiration there is partial closure of the glottis. So that's why someone will have grunting. So even this, you may find it in multiple choice where they ask you, say, why is there grunting? So the reason why a child will grunt is because there's partial closure of the glottis, like I've circled here. That's the reason why there is grunting, because of the partial closure of the glottis. Then there also be chest retractions. Chest retractions, this is the pulling of the ribs and the sternum during breathing. And then this is as a result of labored breathing. That's why there will be chest retraction. So obviously you know what it means, huh? Pulling of the ribs and the sternum during breathing. Then why should there be apnea? Apnea, we know that this is temporal cessation of breath. Why should there be that? So this will happen also in preterm because the lungs are affected. There is atelectasis. That's why this will come in. Then there will be diminished air entry. If you use your stethoscope to auscultate, you'll discover that there is reduced air entry. This is because of atelectasis. Then there'll be characteristic granules, a rice-like grain appearance on the chest because there is, atelectasis. So that's why this occurs. So mostly it's atelectasis, okay, that is presenting here. Then generalized edema within 24 hours. This will come in. Then the child can go into what we call hypothermia. So some will give a reason or rationale for hypothermia to say that there is anaerobic respiration. That's why there is hypothermia, because the child is not producing enough energy from oxygen combining with glucose. That's why the child have hypothermia. Okay. Then hypotension and asphyxia. So these will come in because there is a reduction in oxygen and a rise in carbon dioxide. Then there will be a reduction in the urine output. So this rationale is given because the child is not even able to drink. Okay, so that's the reason sometimes they will say hypothermia. What about the investigations? Let's see about the investigations. So investigations, you can start with history. So under the history, you can check. So you can ask when the child was born. So is this a premature you're dealing with? That's what I'm saying, preterm birth. So if you look at the child or infant you're dealing with, ask the weeks, okay, or gestational weeks. So they'll tell you this is a preterm or premature baby, then you know this is a preterm. So you expect a reduction in surfactant. Then other issues that you can ask in history is maternal history. Under maternal history, you want to know if the mother is diabetic, because we established to say that those infants born from diabetic mothers, they will have a reduction in surfactant production, so you need to know. Or is there antepartum hemorrhage? So you need to know all these, okay? Or was the child born vas-cesarean section? So those who are born vas-cesarean section, it's been believed that they have a delay or a reduction in surfactant production. So that's why you have to ask about this. Then you can also perform what we call physical examination. Under physical examination, you will check, is there nasoflaring? Is there respiratory grunting? Is there a cyanosis? Is there chest indrawing? This is what you're going to check out when you're physically examining this child. Okay? Then you can also perform arterial blood gas analysis, or ABGs. When you're performing ABGs, meaning that you're going to get blood from the artery and then assess the levels of oxygen and carbon dioxide, as well as the potential hydrogen, which is pH. So in this case, you discover that the partial pressure of oxygen will reduce, then partial pressure of carbon dioxide will rise, which is here. Oxygen reduces, then there will be a reduction in the potential hydrogen, meaning that if pH reduces, that's acidic or acidosis. Then you can also perform a chest x-ray. Chest x-ray will show a bell-shaped chest. So this sometimes is asked in your multiple choice or MCQ. They'll say bell-shaped chest, where do you find the bell-shaped chest? So you discover that this is found in RDS. Then air bronchogram. Air bronchogram meaning that you're going to use a dye, and then this dye will infiltrate, or it will outline the parts which are affected, or the air passages, and then this will show you to say that there's atelectasis. Mostly that's what it will indicate. Okay, then other things that are very important about the investigations will be for you to know what we call the lecithin sphingomyelin ratio. This sounds not necessary, but you find it in one word answer or sometimes in MCQ. So they'll ask you mostly about the ratio. What ratio is there? So the ratio is 2 to 1, meaning that lecithin is 2, sphingomyelin should be 1. So this shows fetal lung surfactant deficiency. So they get this. So this is the study where they are able to tell the surfactant levels. So they do what is known as the lecithin sphingomyelin ratio to determine the surfactant levels in the blood. So you need to know that the ratio is 2 to 1, which is normal. So you find this in multiple choice, like I said. Then other things that they do is presence of phosphatidoglycerol, which usually indicate fetal lung maturity. So it will just show you if the fetus, its lungs are mature. That's what is there. Then other studies which are there is surfactant albumin ratio. So under surfactant albumin ratio, you expect this one, which will say it correlates with an LS, which is a lecithin sphingomyelin ratio of 2 to 2. So this one mostly to give you 2 to 2. This is the surfactant albumin ratio. But then the lecithin sphingomyelin ratio is 2 to 1. That's what you expect. Okay, so this is about the investigations that are done. Then under the management, whenever you hear about RDS in the stem of the question, RDS is there. They've brought you RDS. What you should bear in mind is that this child is having a problem with breathing. Should you just manage it using a profenema and forget? The answer is that no, you cannot just go straight to a profenema and forget, because you're dealing with an emergency here. The child is not having surfactant, the lungs are collapsing, the child is cyanotic, the child is hypoxic. So there are a lot of issues that you need to attend to instantly or immediately. So what you're going to do is that you should be able to know that you're going to deal with what we call the ABC first. So your first heading should be resuscitation. Okay, so you're going to have the first heading to be resuscitation, then write A, B, C before you go to the subsequent care. So with resuscitation, so the first thing under A you're going to deal with airway. So under the airway, you're going to look at what you deal with to say you're going to place this child in a neutral position so that at least you allow air entry to be there. Then once you do that, you're going to ensure that the airway or the mouth is clear. If there are any secretions, you can do the suctioning so that you clear the airway. So you first of all position the baby. That's under A. So you're dealing with A. You position the baby so that at least you allow the airway to be clear. Secondly, you're going to suction so that you clear the airway. And if you're looking at maybe say placing an maybe say oral airway, those for infants, you can place it at this point so that the airway is clear or patent. Then when we go to B, under B, this is where now you give oxygen. So provide oxygen 100%. So when you give oxygen to this infant, meaning that you're trying to eliminate that hypoxia, okay, that's what you're going to do. Then at this point, you can also do bagging or ambu-bagging so that you assist in terms of oxygen. Then it's at this point, the third point, if there is need for a CPAP or mechanical ventilation, is at this point at which they ventilate so that you help the infant at least to have enough oxygen. Then under C, you're going to check the pulse so that you ascertain the cardiopulmonary activities. After that, you can also perform the capillary refill time, which is CRT. So it has to be between 2 to 3 seconds so that you know the perfusion or the amount of fluid going into the peripherals. Then under C again, you are going to cannulate the baby so that you provide fluids. Then under C, now provide fluids because the child may have hypotension or the child may be lacking fluids or even glucose. So you can go on and also check for glucose levels so that you resuscitate. If the child is hypoglycemic, you should be able to provide dextrose, meaning that this is the resuscitation part, the ABC. That's the one that you do first. Then after that, that's when now you can go into subsequent care. So after the ABC, which is now go to subsequent. So under the subsequent, this is where now you write your eprophenema. So your eprophenema now will start with EMS. Okay, the EMS, if you put your EMS on top before on management before the ABC, meaning no need of putting them under the subsequent care. You can go to your environment, meaning what should you have in your environment. So this is just the general care that you have. Then apart from that, you go now to maybe say your observations. What are you going to be observing? Okay, so under the observations, you can do a lot. Okay, you can observe the color of the skin, the heart rate, so but you have to be giving rationale. So why should you check the heart rate of the baby? So you need to write it as a point alone and say you want to check the cardiopulmonary activities, okay, or just to check how the heart function is. Then why should you check for the respirations? Because you want to ascertain the air entry or the pulmonary activities. Then why should you check for temperature? This is because you want to detect any conditions such as hypothermia. Okay, that's why I need to do that. So that's under observations. You can also record the urine output because it's very important. We said that urine output can be reduced. So you want to check the urine output so that at least you know if the child is not going into renal failure. Okay, then you can also observe other issues such as maybe the muscle tone, which is here, because we know that the child can have loss of muscle tone in this condition. So check for the muscle tone. So you can observe for a lot of things. This is just a guide, so you can have a lot to observe. Okay, yeah, so you can have a lot. So but oxygen therapy, you're not going to put it as oxygen therapy alone. Just put this under ABC, under airway, the resuscitation. Then feeding, we're going to have a heading under prophenema to say nutrition. So nutrition, this is a point as well. This is a newborn baby who is a premature. You cannot just start by feeding things which are not maybe milk. You cannot start to say, I'll feed Nshima, or feed oranges, or feed what? No. Babies, infants, remember, they depend on milk. So you need to insert a nasogastric tube. So that's the NG tube, okay? So you need to insert a nasogastric tube, then feed via the nasogastric tube, okay? Then after the child improves, that's after some time, you need to begin to try it on cup feeding. Then after that, you begin also now to just put maybe say breastfeeding. So you start with NG tube, cup feeding, then breast. So that's why even NG tube is mentioned here. Okay, so you feed via NG tube, that's expressed breast milk. So that's what we are going to mention. You mention three things here. Okay, insertion of NG tube. Then after the child improves, you're going to start feeding via that's cup feeding. After the child improves from cup feeding, you introduce it to at least breast milk. So you're going to, or breastfeeding. That's what you're going to do here. Then you can do eye care. So these are just maybe say on hygiene. That's hygiene. You can do eye care and mouth care, skin care. So you can do a lot. So this is not all. This is just a guide or a sample. So you can write a lot under prophenema. So let's look at now the prevention of RRDS. Okay, so under the prevention of RRDS, so this is or let me start with the complications, then we'll go to the prevention. Okay, so the complications are, number one, we can have intraventricular hemorrhage. So intraventricular hemorrhage, this occurs in the brain. This is as a result of increase in the pressure, okay, in the brain there. So that's what happens. So there'll be an increase in intraventricular pressure there, so leading to hemorrhage. Then there will be also pneumothorax. You expect air in the chest. So this air is not really in the lungs. We're talking about air in the pleural spaces. So if air is there which accumulates, we call it pneumothorax. So this is because of the differences in pressure, atelectasis, and all that. So that's what we expect. Then there also be a ductus, patent ductus arteriosus, meaning that the ductus arteriosus will remain open because of atelectasis and because of the changes that are occurring in the respiratory system. Then there will be bronchopulmonary intravascular congestion. Like we said, there's congestion because of these blood vessels collapsing in the chest or in the lungs. So that's why the bronchopulmonary intravascular coagulation. So meaning that there's a problem here with clotting of blood. Then sepsis, meaning that there will be infection in the blood because this child will be doing a lot of procedures. So this sepsis comes from there. We're dealing with a lot of procedures, so you expect this sepsis. Then there will be pneumopericardium, meaning that pneumo is air, then pericardium is the lining of the heart. So you expect this air to go and surround the heart in the pericardial space. So it will shift because of the pressure in the lungs. Then there will be pulmonary interstitial emphysema. So this also we're looking at air shifting from the lungs to go into the pleural space. Also sometimes we say under the skin. So this under the skin, you expect it and you'll be able to feel it, maybe say on palpation. So this is as a result of pressure as well. Then let's look at the prevention. If you look at the prevention, we're looking at number one here, to prevent or prevention of premature labors and births. So we're looking at by all means to prevent prematurity. So if you prevent prematurity, meaning you're not going to have the problem of issues to deal with low surfactant. Then if preterm labor is inevitable, meaning that if you're suspecting preterm labor, always give betamethasone. So they give betamethasone in these. Some give prednisolone. Okay, so mostly they give betamethasone for at least 24 hours before delivery, and some give prednisolone. Okay, so it depends with your hospital. So that's what happens, so that you prevent. So these steroids help to increase, okay, the production of surfactant. So you need to inject the mother. Okay, inject the mother so that this drug can reach out to the fetus in utero, so that there is an increase in the surfactant production. Then you can also perform amniocentesis. Amniocentesis will be done to determine what we discussed earlier, sphingomyelin or less than sphingomyelin ratio, so that you know the amount of surfactant available. Okay, if no surfactant, say in liquor, meaning that you're looking at amniotic fluid, if there is no surfactant, then delay the C-section, which is cesarean section, or induction of labor. So this is just preventive measures. Okay, that's what happens. So thank you very much for being with me. So what you're going to do is just study and also find more information, especially on the management, so that you're able to write. At least I've given you a guide. You'll be able to write, and you'll be able to at least know what to do in this care. So thank you very much for being with me, and subscribe if you're not a subscriber. If you're a subscriber, please share this information and click like. Thank you very much. Being with Mr. Coco.